Oh, we already are recording. We will have this on YouTube, so if you have a friend who missed it who might be interested, give us a couple days to put it up on our website and on YouTube, and you can access the recording. And again, this is the February edition of Lunch with Docs. My name is Andrea Merriam. I'm with PMD Alliance. PMD Alliance is a nonprofit dedicated to supporting people impacted by Parkinson's through education and socialization. So we have online programs like the one today, and we have in-person programs as well. We've had 3 so far this week. So check out our website to learn more about us. And without further ado, I will turn the floor over to Dr. Samanta. I'll give a brief intro. Dr. Samanta is a movement disorder specialist, so a neurologist with advanced fellowship training in movement disorders. He's in private practice in the Metro Phoenix area, and also an associate professor down at U of A, I believe, Dr. Samanta. And he is just so personable and such a good listener and has such a good way of translating these difficult topics to so that lay people can be able to understand them. So thank you for joining us on your lunch hour, and I'll have you take it away, Dr. Samanta.
All right. Well, thank you very much for that kind introduction, Andrea. Today, I think we're talking about restless leg syndrome, and which is kind of a broad topic. So it's something that doesn't necessarily specifically affect just people with Parkinson's. It's a kind of its own freestanding disorder, though we do tend to see it occur maybe a little more frequently in folks with Parkinson's, and there are some reasons for that. But I guess for anyone, if you've ever been sort of laying in bed trying to read or watch TV, or you're sitting on the sofa in the evening and trying to read a book or just sort of do something quiet, and this sensation starts welling up, usually in your legs, but sometimes even in your body, that just is sort of a hard to describe kind of tension, and you just find that you're stretching, you're kind of tensing and flexing your legs or your body, and sometimes you don't realize you're doing it until your significant other, your family member says, "What are you doing? Why are you squirming?" Well, that is restless legs. It's a little bit of a misnomer, because it doesn't just affect the legs, but we classify it as a movement disorder, but it for a lot of folks, the movement is not entirely involuntary. It's really the sensory part of it is what people experience, and the movement is a response to try to quell that feeling of discomfort or tension. I think the best sort of vernacular to describe the sensation is it's the heebie-jeebies. I think that's if you're old enough, which I am, whether I like it or not, to kind of have that term resonate with you, I think that's the best term that kind of gets across the point of what this is. But for a lot of people, and there are some studies that say, as much as 20% of the population at some point experiences some symptoms of restless legs, maybe not on a nightly basis, but periodically. I certainly have experienced it myself. It can, so it's in that sense, it's one of the more common movement disorders, and possibly the most common one. And for the vast majority of folks, if we're going to take that 20% of the population number, It's an occasional thing, it's sort of an odd event that it may happen, on a late at night, maybe after a particularly stressful day or long day, but is not a regular occurrence. Now, for the the lucky, if you will, few, which might account for still a couple percent of the general population. It's a more regular or a recurrent issue, and when it is that, it can be fairly disruptive. So if you imagine you're in bed and you can't get comfortable, there's that tension, there's sort of this building discomfort, and it's very hard to get back to sleep if you feel like that. You can't relax. You need to get up and move your legs around. That is kind of the physical experience of restless legs. It typically is something that occurs more at night, or as part of that, in sync with your own day-night cycle. But again, there are cases where folks can have some of these symptoms all day long, or they're just worse at night, but they're there, and that can make things like going to a movie almost impossible, or having to get on a flight and fly to the East Coast, or if you're on the East Coast, fly to the West Coast, for to be cooped up in an airplane seat for a few hours can really be terrifying, or certainly something you wouldn't look forward to, and can really limit folks in that sense. And I mentioned that we do see it in Parkinson's as well, and the frequency there might be in terms of more recurrent or persistent symptoms, maybe not daily, but multiple times a week. Is probably at least 20% of people with Parkinson's at some point are aware of some restless leg type symptoms. And in those cases, more often than not, it's kind of part of that phenomenon that we call motor fluctuation or wearing off. And so it tends to be associated with that period for folks where maybe they're due to have their next dose soon, but that previous dose of medication's already kind of waning a little bit, and they might have, before they notice a tremor or that they're stiffer or slower, they just get a little bit uncomfortable. And from everything we can, we understand, what they're describing is pretty classic restless leg symptoms. And there may be a reason why people with Parkinson's seem to also experience restless leg symptoms. The reason behind that is that both classic or what we call idiopathic, so it's not associated with some other disease, restless leg symptoms are linked by dopamine activity. And there does seem to be evidence that people with restless leg syndrome have lower levels of dopamine activity in certain areas of the brain. Now, as it turns out, having a history of restless leg syndrome does not predispose you any more to Parkinson's than having blue eyes or blonde hair or anything like that. So, but it is maybe associated a little bit more with things like ADHD, and oddly enough, in some cases, there are some studies that seem to indicate that you may have a higher likelihood of also having a central tremor. So, and so things can get kind of confusing, and I don't want folks to worry too much about those things. It just seems like that there are some little overlaps with other conditions, but Parkinson's isn't necessarily one of them if that's the only issue you're having. But it does kind of establish, at least with that overlap with ADD and the fact that folks with Parkinson's can have restless leg syndrome or symptoms as part of their meds wearing off, it does establish that link to dopamine activity being somewhat different in folks with restless leg. And I think the sort of the association with ADD probably makes the most sense, because we also have a lot of research that shows us that folks with ADD seem to have lower levels of activity in certain areas of the brain of dopamine as well. It's not necessarily that you're making less, but just that there is less interaction of dopamine, either stimulation of receptors or release of dopamine in certain areas of the brain. And that's why stimulants seem to help ADD. And it's probably why Parkinson's drugs, interestingly enough, seem to be very effective and really the treatment of choice in restless leg syndrome. Unlike in Parkinson's disease, we don't see nearly the same kind of escalation of the dosage over time. So the doses tend to be much more stable, but they can change somewhat over time. So it is something I think that there's a fairly simple way to treat, but simple or straightforward as it sometimes is or often is to treat. The hard part is sometimes getting your healthcare providers to recognize what you're having. And I think it comes back to that ultimately it is often very hard for folks to describe what they're feeling. And so there's a tendency to maybe be misdiagnosed as maybe having neuropathy because maybe you're having pain or burning, or be treated for muscle cramps because your legs hurt or they you're flexing the muscles and they look tight and tense, but that's really your reaction to being uncomfortable. And so sometimes folks can go quite a while, can go a few years even before, 2 and 2 gets put together and they say, oh, wait a minute, that's restless legs. And as I said, like the treatment of choice is really, is to use a dopaminergic or a dopamine-like drug. Usually the medications are in the family of what we call dopamine agonists. So they're kind of synthetic dopamine, or they look like dopamine to the brain. And these are like the Parkinson's meds like pramipexole or Mirapex, ropinirole or Requip, or rotigotine, which is the Nupro patch, and all of which over the years have also been approved for treating restless legs. Typically, the doses are a bit lower than what we might reach treating Parkinson's, so that also differentiates restless leg syndrome from Parkinson's disease. While just like in Parkinson's, we don't just use the dopamine agonist, we can also use levodopa. Levodopa can work very well for restless leg symptoms as well. However, what we find is, just like in Parkinson's, where the shortcoming of levodopa is, gosh, it's effective, but it doesn't stay in your bloodstream very long, is that it can become frustrating to use with restless leg as well. And folks sometimes get rebound symptoms when the level in their bloodstream drops, or with other shorter acting versions of it, or they'll find that, gee, gosh, it worked so great for a while, but now I feel like I notice my legs bothering me a couple hours earlier than I used to. So now I'm taking it twice, and so it can become what we find is it's a better drug to use as needed or for breakthrough symptoms. So if you're going to get on an airplane and you don't want to take an extra dose of, say, your Mirapex because maybe you feel like it makes you a little too drowsy or something. And, then you could take some carbidopa levodopa, um, and it will work very quickly, and it should last, long enough. The effect should last more than long enough to get you through an airplane flight or a movie or something like that. And if you're not using it every single day, you're not likely to have the issues with, say, yeah, the amplification of your symptoms, earlier symptoms, or rebound symptoms, or things like that. Uh, and just like there are drugs, like, there are like anything else, they're kind of the core drugs that work, but folks have observed a lot of other medications sometimes can be helpful as well. So some of the derivatives of gabapentin, or Neurontin is the old brand name, um, uh, have been shown to be helpful as well. And so if for whatever reason you don't tolerate, say, the Parkinson's type drugs because they make you nauseous, or they affect your blood pressure, or things like that, then that's another option. And that's a fairly safe drug. It was developed, for epilepsy originally, but quickly sort of proved to be very effective in treating a lot of other neurological symptoms, neuropathy, pain, migraine, um, just to name a few. There's really a pretty long list of areas where it's been used. And then one of the other areas where it's used, and derivatives of it are used, is restless leg syndrome. And so as a drug, it's different than the dopaminergic drugs. It may be a little more likely to have you feel a little dizzy or sleepy than some of those. It's not likely to make you have it, give you issues with nausea or GI issues. Um, but as it is originally an epilepsy drug for folks who've been on it for a while to treat their restless legs, so months, you don't want to stop it abruptly. It would be a drug that you would taper off of, so that just to avoid any risk of having like a withdrawal seizure, which can happen with anti-seizure drugs. Not terribly likely. Usually, you don't require really high doses of it to treat restless legs. And interestingly enough, especially in the current world we are all living in right now, historically, opiates have actually worked well for restless leg symptoms. And it's not clear why that is. They don't really work in the dopamine receptors, whether it is something that some other receptor that they're hitting that directly helps the symptoms, or whether it's more of sedation or kind of dulling your sensation and awareness. It's not quite clear, but more and more we tend to avoid using those, except for maybe some of the very mild ones. And again, for those, it's more of an as needed, or like a breakthrough type of like a rescue treatment, as opposed to something that someone would want to be using every day. And then I think the last group that seems, from a pharmaceuticals kind of standpoint, are the benzodiazepines. So those are the anti-anxiety drugs like Valium or Xanax or Ativan, can also help with restless leg symptoms. Again, I don't think they're working as directly on where the issue is, but they probably reduce some of the signaling and kind of calm things down in the central nervous system enough that can be helpful. Again, probably better used as in a situational setting, as opposed to something that you'd want to be taking every single day. Um, as obviously there are concerns of them being habit forming, or dependency, and and the like. So there are certainly many options in the prescription side of things. I think also restless legs are one of the areas where you will see some of the most creative uh, home remedies. And while I think, I can't verify all of them, but I certainly have had folks swear by some of these, and they're low risk enough that I think, everybody who has restless legs, it's probably not going to hurt for you to try them. Yeah, I just, they're ones that I couldn't personally vouch for how likely they are to succeed on average. But very commonly, folks will use things like a little calcium supplement or magnesium supplement at night, and that may be helpful, especially if there is a tendency to cramp up when you're kind of relieving the stress. And usually folks are just following kind of the milligram guidelines on the vitamin, on the supplement bottles. And there aren't too many risks to taking those. So with calcium, maybe a little more constipation. With magnesium, a little more of the opposite, potentially some loose stools or diarrhea as you take more. But magnesium works as a muscle relaxant, and calcium is important in muscle electrolyte balance. So it's an important electrolyte in muscle firing. Um, and there are folks, just even, things as simple as chamomile or using, some of the neuropathy ointments or creams. So some of the capsaicin cream and things like that. I have folks who will swear by that. I have other folks who've tried those things and didn't do a darn thing. I think one of the more interesting ones is, and I am surprised at how many people endorse this, is putting a bar of soap under the covers with your feet. I have no scientific basis for why that would work, other than it may just be something that you bumps against your legs, and maybe the the oiliness or whatever, that kind of the texture, the touch of that soap on your skin as it moves around may have some, give you a little bit of sensory feedback. I will say, maybe along those lines, for a lot of folks, even I will say for myself personally, doesn't mean it's going to work for everybody, but I putting a pillow between your knees, or rolling some of the comforter up and tucking it between your knees when you're laying in bed, sometimes we'll just put enough contact and sort of sensory feedback uh, into your legs that sort of distracts or dissipates some of that discomfort. And probably when I talk to over the years talking to patients, that seems like one of the more consistent, non non-pill, non prescription type of interventions or compensatory techniques that seem to be helpful for kind of milder symptoms. I think if they're more severe or more persistent, it really does need it a medication to get under proper control. Um, when in folks who come to me and they have, they say, gee, I've got these symptoms and they're really troublesome, there are some things as a doctor that we want to look out for or check for. And so one of them is to look at B12 levels. So sometimes if your B12 levels tend to be on the low end, that can be associated with essentially kind of a form of nerve dysfunction or neuropathy that may present in some folks as restless leg symptoms. restless leg symptoms have also been reported in folks with thyroid dysfunction. So making sure that the thyroid levels or thyroid stimulating hormone levels have been checked in, at least somewhat recently is important. I think double checking for risk factors for neuropathy, because sometimes neuropathy can be hard to distinguish. It may not be a real clear burning. It might be just a discomfort in your legs. And so, checking for blood sugar and hemoglobin A1C, screening for diabetes, screening for inflammatory or autoimmune uh, disorders and the like, which is just blood work, is not a bad idea. And in folks with restless legs, particularly the first kind of recognition was in women of childbearing age. What was noted was that often during pregnancy or around the time of menses, that restless leg symptoms sometimes could be exacerbated or worse. And what the association that was sort of discovered after a while is that often in those folks, their iron stores are lower. And so we also check a couple of the markers for your iron stores, not so much your total iron, but something called ferritin, which is a kind of your long-term stored form of iron. And if that's low, there are at least a handful of studies that show replacing it and getting it back up into the normal range can greatly reduce restless leg symptoms. Unfortunately, it is not an overnight process, so it often takes 3 to 4 months to kind of get the results from it. But certainly it wouldn't be outrageous to sort of treat the symptoms in the meantime, but also make sure that you get those lab numbers kind of back into a normal range. And oftentimes those folks can, if not get off of medication, they can certainly be on less than what you started. And then if we can get the same results with less medicine, that's always good. Let's see. I think that is that's like sort of the big nutshell of restless legs. So maybe it's a good opportunity to open up for questions or comments from folks.
Yeah. My first question would be, so when would you recommend people see a doctor for this? When does it, because it sounds like in your personal example, it's something that you just kind of live with, and sometimes it's, it's an annoyance, but when would you recommend for people to take the step to see a physician?
Sure, that's a great question. Because it's not typically something we'd associate with, say, something life-threatening, like cancer or heart disease. It's perfectly reasonable if it is occasional and doesn't really interfere with your day-to-day function or quality of life, to just, try some of the home remedies. But the kind of, if you don't want to go see the doctor about it, it's probably not the worst thing you could do. But I think anyone who, where it is affecting the number of hours of sleep they get on a regular basis, or it is contributing, to you maybe not going out socially or not traveling or avoiding certain things, well, here's something that's typically very treatable, and it's having a negative impact on your quality of life. So that would absolutely be the setting where you'd say, well, gosh, let's go get seen and see if something simple might be able to give you that quality of life back. So really, I think everybody has a little different line, but I think there is no reason that you should have to tough it out if it is impacting your quality of life. So even if that means a couple times a month, but it really disrupts things, that I would go in and be seen. Um, I think
What
there's
if you have Parkinson's? Would that be, an off, something to talk to your doctor about off time?
Yes, absolutely. So if you're a patient with Parkinson's and you realize, gosh, I get those kinds of symptoms, and it could be sometimes those folks will come in and they're getting it 4 times a day and it's after each dose, and sometimes it's just no, I just get it at night. Well, so sleep is certainly for the folks that just get it at night. Sleep is even more important for someone with Parkinson's than it is for the general population. So I think it's valuable to bring that up. If it's whether it's just occasionally at night or whether it is something that happens consistently at the end of dose, because they're both telling us, you and your doctor, that there is some shortcoming in the way your meds are working. And while it might not be terribly disruptive initially, we know Parkinson's is progressive, and so it's likely to get more noticeable or more persistent or more prominent over time. So we may as well, it may as well make us aware, and we may as well as a team be working on ways to undo that. So yeah, I kind of low threshold for coming in and mentioning it.
Okay. And what about exercise? I know anytime I hear something's related to dopamine, my mind immediately goes to exercise.
Yes, so yeah, and that's I'm glad you brought that up, because that is one other area that I missed talking about, or one area that I think that I realize I missed talking about is, for both Parkinson's and non-Parkinson's restless leg, exercise, and I would say kind of low to medium intensity exercise. So not maybe, a Pilates class at, 9 o'clock at night, but getting on a treadmill, going outside for a walk, doing some yoga stretching for 15 minutes, things like that often can kind of help, probably because they do raise dopamine levels a little bit. You don't want to be overstimulated so that you can't fall asleep because you're just so darn awake now. But in that kind of mild, low to medium intensity activity, just enough to get the endorphins going a little bit, that can often help. And then the other thing that just triggered is some folks like a warm bath or a hot shower before they go to bed can be helpful too. Not that relates to exercise, but just the one other thing that I had neglected to mention.
Okay. And we had a question from Mary. She says, I get restless leg syndrome about 3 to 4 times a month. I try to keep track of when I get it and what I did that day, but to me it seems completely random and I can't figure out what triggers it. Is that common for everyone with restless leg syndrome?
I would say that is very well within par for the course. I think there are there's certainly going to be days where you say, oh, gee, I was on my feet all day and I did this and that. And yes, it's not shocking that my legs are bothering me more. But for a lot of folks, including myself, I don't really know what I did, or it isn't really obvious most times why my legs are bothering me. Maybe I'm up a little later than normal, but oftentimes it's not drastically different than my normal routine. It's just some subtle biorhythm that I think that probably has more little factors going into it than we can easily track or perceive on a day-to-day basis. So yeah, I think there are some things that we recognize probably are more likely to lead to a worse evening, but that you can't, but the fact that you can't identify those easily is not a, is not a failure on your part, or nor does it mean that there's something different about your restless leg symptoms.
Okay. And this is kind of a comment. It's kind of interesting. John said that I have Parkinson's, and from your description, I think my wife has restless leg syndrome as well. So finally, we share a Parkinson's symptom. So there we go.
Oh, right. Yes.
I don't know if that's a good thing, but
I guess it's sensitivity training for each other there.
yeah.
Yeah. Yeah.
Okay, let's see. Sheila in Tucson asks, is there a link between Dramamine and restless leg or body syndrome? I've noticed its recurrence when I take this med for my vertigo. I also have low iron, and good to know that might also be a cause.
Okay. Yeah. Well, I'm glad that part was helpful. And so Dramamine, so it has some properties that may aggravate restless legs, and that's great. You had reminded me of one other thing I should have talked about, and that's, there are certain medications that potentially can aggravate restless leg symptoms. Most commonly, the medications that have what we call an anticholinergic effect. So there are a couple of Parkinson's meds that we don't use much of anymore, but they're Artane or trihexyphenidyl and benztropine are the kind of the two most common ones. They're used very little in Parkinson's anymore, but kind of used for tremor in the past. And then some of the antihistamines, and Dramamine is basically an antihistamine, which can help folks with intermittent vertigo or middle ear issues, but I think reasonably could aggravate or kind of stir up your restless leg symptoms. On the plus side, that seems to be an effect that only persists while you're taking the medication, and doesn't seem to lead to any persistent worsening or any long-term downside. But so that's Benadryl, it's your Zyrtec, it's those kinds of things. Any medication that gives you a lot of dry mouth may potentially aggravate. So some of the anti-bladder medications, so overactive bladder medications, can sometimes also be associated with some increase or aggravation. And some of the older antidepressants that we now use for nerve pain, ironically, so like amitriptyline, nortriptyline, what we call the tricyclic antidepressants, sometimes can aggravate restless leg symptoms. And I think did we cover both parts of that question? I think so.
Yes.
Okay.
I think the second part was just a comment about the iron being a contributing factor. Okay, and maybe you'll probably know what this is. The question is, what do you have to say about RLS augmentation?
So augmentation is this phenomenon that I sort of alluded to earlier, but for some folks, they start treatment with, and we see it with the dopamine agonists. We see it more clearly and more often with levodopa because it's shorter acting. But they start taking their med at say 10 o'clock, and it works great. But over time, they start to notice, gee, it's 9 o'clock and my legs are bugging me. And then when I do take my pill, it takes another hour for it to kind of calm down. So that tendency for the symptoms to shift a little earlier is, in the day, or be a little more intense or more obvious earlier in the day is kind of the crux of what augmentation is. There's also sometimes some rebound. So maybe I take maybe I take an extended release Cinnamon at bedtime and it works great, but at 3 a.m. I wake up and my legs are driving me nuts again. And that's kind of rebound. And they never used to be that, it didn't ever seem to be that intense at 3 a.m. before. And it's a little bit of that whole thing of, when you're affecting a system, it tries to makes little adaptations whenever we interfere or try to help out the function in the brain. And so there may be some, especially with shorter acting or more peak and trough kind of medications, which most have a pretty good peak and trough kind of effect. It's just the way we absorb meds. That restless leg in particular can kind of develop, start showing up a little earlier and be a little more intense, or it can kind of come back at the end of the dose a little more intensely. Doesn't happen to everyone. It is not, so it isn't futile to treat, that's very important. But in those cases where that happens, those are folks that maybe in particular want to look at like the extended release versions that have more of a 24-hour release and level of some of the medications, or the patch where there isn't going to be a distinct peak and trough. You're going to have a more level dosage or coverage through the day, and that seems to very effectively inhibit or prevent the development of augmentation.
Okay. I'm going to read this next question, and I'll just preface it. I know that you're not, it's hard to give medical advice over the video chat, and you're not looking at these people's histories, but I will read the question, and maybe, you can have some general ideas or answers. I have PD and RLS. The RLS got so bad, I go days with no sleep. My doctor has tried several prescription sleeping pills, but none have worked. He's even prescribed heavy pain meds, but they don't help. Any suggestions?
So let's see. So I'm going to assume that this person is already on long-acting dopamine agonists and that they're already on levodopa. That is, it's certainly uncommon, but it is not unheard of. There are always extremes on either end of the spectrum. In the instances where I've run across similar situations, the first thing I really try to ensure is, am I missing something? Is this definitely are these definitely restless leg symptoms? Could this be dyskinesia? Could it be dystonia as part of the fluctuations? And it's just the outward manifestation is subtle enough that all they're really, what you're experiencing is the discomfort, but it might not be really obvious to see that there's a lot of squirming, or the ankles are turning, or the feet are curling, or toes are curling. And so I would really investigate that, which is mostly physical exam. There may be other things, sometimes an EMG or needle study or things like that. It might be helpful. Or could there be a neuropathy component and that is mimicking the RLS? Again, I would look at the metabolic things. Is the thyroid okay? Is there are the iron stores okay? Is there any other factor I've overlooked that might be causing, making this harder to treat, that we might have missed? That's kind of, for me, the starting point, at least.
Okay. Let's see. is restless legs ever in one leg only, or does that mean maybe it's something else?
So in the setting of sort of just a single limb, I will say it should at least make us think about things like neuropathy, things like sciatica or a circulatory issue or something like that. But at the end of the day, I have certainly had a couple of patients over the years who maybe you know it wasn't completely one leg, but it was 90% of what they were perceiving and experiencing was in one leg. And if we really, really pushed it, yeah, there's a little discomfort in the other leg, but boy, it really is pretty much. So for all practical purposes, it was one leg. It does happen. It shouldn't, I guess I would say it makes you want to double check things first before you just let it go as being the unusual case, but it can be.
Okay. Um, I've never heard of the capsaicin cream. I'll try that. What about CBD cream?
If there's if there's an ailment that that's either involves sensation or pain or muscle tension, I think someone has tried CBD cream for it. Uh, the truth is there's not a lot of data. There's not much published specifically on RLS and CBD cream. I think I'm sure I've had at least one or two patients who have tried it and thought maybe it was helpful. um, I would put it in that group of of sort of non-traditional remedies that some folks may benefit from, in that I would say don't appear to have a significant risk associated with trying them.
Okay. And I know you mentioned calcium and magnesium. Someone asked, what about melatonin and taking vitamin B12 supplements?
So B12 supplements, certainly if you have diagnosed, or documented low B12 levels or potential or suspected insufficiency of your B12, it may be helpful. There isn't any evidence that sort of what we say empirically taking B12, is likely to be helpful for a typical RLS sufferer. The melatonin, where melatonin may have some benefit, so it doesn't appear to be, directly beneficial for the RLS symptoms, but it may help establish or reinforce kind of your day-night cycle, which probably does play some role in why some days are worse than others with RLS. So it may be helpful in a secondary kind of way.
Okay. And then there's two comments that are kind of similar, that the RLS symptoms go away when they stand up, which is that, normal or a good kind of,
That's very typical. It's any movement, but certainly, yeah, getting up, walking around. It's same. Most folks will tell you, if I'm moving, I don't have, I have little to no awareness of any symptoms, and it's really just when I'm still and trying to relax, and while, like I say, it tends to be at night, but there are folks who have it in the morning. It tends to be focused in the legs, but there are folks who will have all over symptoms, or they feel it in their arms or their torso. And they describe it kind of like, when you go over the crest on the roller coaster and you're starting to go down, you get that feeling in your stomach, like getting that sort of through your body. And so just because you're more aware of it in your torso or your arms, doesn't mean it's not restless legs. It's just, it was named when that was the most clear-cut kind of cases that people were seeing, and kind of, and the sort of diagnostic criteria were were established. There's been a push for many years to change the name, but it's one that we all recognize, so it
Yeah.
tends to persist. Yeah.
Mhm. Okay. And the next question is, what about the cramps later that night or the day after? What can I do to help with those?
And they really are typically, they're part of our response to being uncomfortable. So we are flexing and stretching and moving and contracting our calves more, and calves in particular are probably the most prone muscle to cramp, in our body. They're just very high tensile muscles, um, and so the best way to avoid it is to have better symptom relief or control at night. But hydration, magnesium, calcium, those things probably are helpful too. Um, a little bit of, some, just be able to rub the calves out, or rubbing them a little bit in the morning may help reduce some of that. But it is, the cramping is almost always part of your response in trying to avoid that discomfort. And so if you can get better control of the symptoms, you're much less likely to have cramping otherwise.
Okay. And I think this is probably going to be the last question. It's kind of a big picture question, which maybe we're putting you on the spot, but it's about your connection between ADD and restless leg syndrome and Parkinson's. They wanted to know if there's any research that ADD in children might lead to a Parkinson's diagnosis later in life.
So I can say pretty definitively that whatever data is, whatever studies have been done, don't seem to show any higher risk for ADD or ADHD, and developing Parkinson's. And just like people who develop restless legs in their young or mid adulthood don't seem any more likely to develop Parkinson's down the road. I think that holds true in ADD, ADHD. But it's something that folks have wondered about, because there is this dopamine connection. But that seems to be more of a static kind of a wiring thing, as opposed to a degenerative thing, or like a priming type of thing, where maybe, oh, your system's been a little out of balance your whole life there, and eventually that imbalance causes other changes. That does not seem to be the case. It doesn't mean that people with ADHD and restless legs don't get Parkinson's. It just means that they don't seem to get it at any higher rate that we can tell, than the rest of the population.
Okay, that's good. I think that can put a lot of minds at ease, right? Because there sure are a lot of, there is so much more of an awareness of ADD and ADHD. So,
Absolutely. Yeah.
okay, let's see. Let me make sure I didn't miss any other questions in the chat. David said usually when he stands up and walks around and takes a single dose of magnesium, it goes away. And he does get it only in one leg. So
Yeah.
there you go. Like you said, sometimes can happen. And would, I assume this is maybe difficult, but would chemo maybe be one of those triggers that you said, that whenever a system is.
Yeah, I think sort of, I've certainly heard that with chemo, and I suspect it probably some forms of chemo more than others, some forms, and maybe it's also some of the other medications that you're given to compensate for the chemo or prevent some of the side effects that may aggravate RLS. But yeah, that is definitely another setting in which RLS can, either be unmasked or exacerbated.
Okay. And let's see. What about pain in one leg in the calf area and swollen ankles? restless leg syndrome, Parkinson's, or question mark?
Yeah, I would say so. When there's definitely pain, and it is, it clearly not just unpleasant or those things, but it hurts, it aches, or there's a burning, or if there are other physiologic changes like swelling, puffiness, redness, that almost certainly takes it out of the realm of restless leg syndrome. There can be some pain, cramping, some increased puffiness in people with Parkinson's on their affected side sometimes. So there's the possibility of that, especially if maybe the pain fluctuates with your medication doses. Um, but if it's, say, your less affected side, or it doesn't seem to have anything to do with your meds, I think you want to at least explore it as though it were its own separate symptom, because it could be circulation, it could be, it could be neuropathy, it could be, a few other things.
Okay. When it gets out of that heebie-jeebies realm, I think that is a
Yeah.
great way. I'm always going to remember that,
Yeah.
where it's a little indescribable, like you said, uncomfortable, restless, heebie-jeebies.
Yep. I've yet to find a better word that kind of resonates with most of us. So.
Very good. Well, thank you, Dr. Samanta, for sharing your time with us. We know you have a busy clinic going on, and thank you to all of you who joined us out there in internet land to learn a little bit about restless leg syndrome. Be sure to send us if you have ideas. I mean, I think this was a direct request, and this was a great topic. We're always looking for requests from the audience. If there's a angle on Parkinson's that you have questions about, we are very responsive, and send it to us, and sometimes within a couple months we can find a movement disorder specialist who's also interested and raring to go to educate people about it. So that concludes today's Lunch with Docs. And again, thank you so much, Dr. Samanta, and thank you everyone for joining.
All right, thank you.
Okay, bye now.